Let's talk about diagnosis. You've received a lot of diagnoses over the course of your treatment, mostly bipolar disorder. But when we talk about diagnosis in psychiatry, it's not exactly the same as the rest of medicine. In the rest of medicine, we're looking for a blood clot, we're looking for a cancer, we're looking for a broken bone. We can find those on various kinds of scans. And we don't always get to see that in psychiatry. The brain's too complicated, and we don't know enough about how it works to do that. So what we do in psychiatry to make a diagnosis is we listen to your story, your life, and then we go to our textbooks, and we see if we can find something there that looks like your life story. And if we can find something that's a pretty good matchup, then that gives us a clue as to what might be useful for you in terms of treatment, because we've studied the people in our textbooks, and we know what works for them. So a diagnosis in psychiatry is less about being right or wrong, and more about being useful or not useful. Now, up until now, as we've talked about your moods, we find that they go up and down, and if you look narrowly at mood, that's bipolar disorder. But if we get out the wide-angle lens and look at your life, if we look at every aspect of your whole person, how you deal with other people, how you deal with stress, how you conceptualize yourself, your mood, your behavior, your social interactions, all of those things, if we look at all of those, we see that there's instability in all of those areas, not just in your mood. And the treatments that you've received up until now for the bipolar diagnosis haven't been especially effective. So maybe it's time to look more broadly instead of more narrowly. So I spent some time after meeting with you, thinking about what you told me, looking in our textbooks for things that looked kind of like your life story. And I found one that I think is a pretty good match. It's called borderline personality disorder. Borderline personality disorder is about instability across a broad range of things in a person's life. And for the reasons that I just explained, I think that might be worth thinking about for you. Now let me tell you a little bit about what we know concerning what's happening in borderline personality disorder. We actually have a few studies that look at the functioning brain in borderline personality disorder. And they tell us a lot about the experience that you've described for us. Now, one of the issues that you experience is very intense moods, very intense anger, very intense depression, sometimes the opposite of that, but often those negative moods. And when we look at the scans, brain scans of folks that are having those very intense emotions, we find that the area of the brain that is most active during those times is a part of the brain down deep, in a very primitive part of the brain. A small structure called the amygdala is where a lot of that originates. The amygdala is a structure that we share with animals going clear back to reptiles. When something happens, when an input comes in to the brain, when you hear some bad news, when you see something that's upsetting to you or that's frightening for you, the amygdala is the structure that responds most rapidly to that. And what we see in folks with borderline personality disorder is with all kinds of different stimuli, that amygdala really lights up. It lights up more brightly than it does in other people who don't have that same disorder, don't experience the same kind of symptoms that you do. Now, the amygdala sends out messages. It sends out messages to the areas of the brain that are responsible for making the heart beat harder, for getting your breathing going more, getting ready for action. It sends messages out to the motor parts of the brain, gets your muscles tense and again, ready for action. But it also sends out messages up to the front part of the brain. Up here in the frontal lobe of the brain, the most human part of the brain, there are areas that are also receiving messages from the amygdala. Two of those that are especially important. There's an area there in the frontal lobe that's responsible for what we call executive function. It's responsible for making things happen. The neuroanatomists call it the dorsolateral prefrontal cortex. You don't need to know that. It's just up there in the front of the brain. And what we find is that for a lot of folks with borderline personality disorder, the message from the amygdala hits that area of the brain, and it also lights up very quickly and very strongly. And then finally, right in the very frontmost part of the brain, in what we call the medial prefrontal cortex, there's an area of the brain where we reflect on things, where in most people, when the amygdala is activated, that area lights up very strongly right away as well, and allows us to think about what just happened, to decide if it's important or not, and how to react to it. And then for most people, there's a signal that quickly goes back to the amygdala and lets the amygdala adjust. It'll calm the amygdala down if the threat is not real. It will keep the amygdala going if the threat is real, but it's an important area of feedback to the amygdala. And what they found when they looked at the scans of folks with borderline personality disorder is that that area of the brain does not light up. There's no reaction there at all. And if it is stimulated by conversation or other interaction to get it to light up, there's no feedback to the amygdala. That connection, that pathway, doesn't seem to be operational at all. Now that corresponds really closely to what you told me you experience. Small things happen. You feel like the emotion that hits you is stronger than how it seems to affect other people around you. That's exactly what we see in those brain scans. You take action, often impulsive action, that afterwards feels like it wasn't the right thing to do. And again, that's exactly reflected in what we see happening in the brain. And it's hard for you to get a handle on things. It's hard for you to reflect and to consider that maybe that reaction was overblown until much later. And again, that's precisely reflected in what was seen in these brain scans. So what can we do about that? Well, first of all, it's important to understand how that happened. We know that the structure of the brain is affected by genetics, by what you inherit from your family, but also strongly affected by what happens in childhood and childhood experiences. Those pathways require certain things to happen and not happen during critical periods of childhood. They develop best in a situation in which you're in a safe, trusting, supportive environment as a child. And what you've shared with me was that that didn't represent your childhood at all. And during that critical period, it appears that those pathways, those connections, did not have an opportunity to form the way they do in other people. And so it's not surprising that you'd find yourself in this position now. So what can we do about that? Well, one of the things that we know is that the brain's flexibility, the brain's capacity to make adjustments continues well into adulthood, in much the same way that if you didn't have a chance to learn a language in childhood, you can still learn it in adulthood. It won't be as natural as the learning of a language early on. You might always speak with an accent later, but people learn languages all the time. But we know how much effort it takes to do that. It takes many, many hours. Actually, we would think of it in terms of months and even years to develop really high-level language skills in a second language. What we propose for treatment is that you do the same thing in developing these pathways. We need to retrain your brain so that these pathways work. And there's several ways to do that, but one of the most successful is dialectical behavior therapy, DBT. DBT is a set of exercises that you can do. Learning what DBT isn't really what's critical. It's the practice over many, many hours, over months, over years of practicing those skills that allow the brain to be retrained, that allow those pathways, those connections to begin to function. And what we find in the folks with DBT is that often after a couple of years of work with this, that those areas of the brain that are supposed to be connected show the kinds of connections that the rest of the population already enjoys, and it allows people to be able to respond more appropriately to bad things that happen, to reflect on those things and not to be overwhelmed by them, to go on then and live their lives in ways that you haven't been able to do up until now. And we found that that's an effective way to do things. But it's important to realize that it's not a simple fix, that it's something that's going to take time. And it's also important to understand why it was that the medicines weren't very successful for you, because they were trying to change what was happening in pathways that actually aren't even there, that aren't operating at all. We've got to get those pathways going before anything else that we do is going to be very helpful.